Our next speaker is Dr. Jennifer Goldman, Professor of Pharmacy Practice at the Massachusetts College of Pharmacy and Health Sciences. Dr. Goldman also is a clinical pharmacist and the clinical director of the cardiometabolic program at Well Life in Peabody, Massachusetts, or is it Peabody? I'm never sure which is the appropriate. And precepts Doctor of Pharmacy students and postgraduate residents and fellows. Board certified in advanced diabetes and management, she has presented at local, national, international pharmacy and medical conferences and has served on state and national public health and diabetes boards. Dr. Goldman also has received awards for scholarship, teaching, and service from NCPHS and external organizations, and has numerous publications in the areas of diabetes, cardiovascular disease, and education. Join me in welcoming Dr. Jennifer Goldman, who will present Demystifying Birth Control, a review for the pharmacist.
Hi, can you hear me okay?
Yes, we can.
Am I on a big giant screen?
Yeah.
Okay, I'm gonna share my slides. And I'm gonna give you a moment to be able to read this one, everybody out there. So normally when I'm teaching that in school at MCP, I kind of leave this up there for them to contemplate. So I think if all of you out there were paying attention to that introduction, you might be thinking to yourself, if she's a diabetes person, why is she talking to us about contraception? And that's a really good question. And I'm going to explain it to you. Let me just, everybody have a chance, hopefully, to read this. And for this presentation, it is going to be interactive. So hopefully we'll be able to use the chat box for those who are online. And for those of you that are live in person, I might not be able to know what you're saying, but I want you to work together. So in order to have that while you're in person, everybody needs to have two documents. One is the handout, which you'll see on the screen, but the other one is the Dickey table, which I'm going to explain to you. So I am going to spend this time together demystifying birth control pills. At least that's what I'm hoping to do. And just to give you, I'm going to stop sharing for a second so I feel like if you can see me and I feel like I'm talking to you a little bit more, is how this happened, how I ended up teaching contraception. And I've been teaching it for over 20 years. Sorry, it's real life. I'm home. I actually have 3 dogs and 2 of them are locked up. Stop. Somebody's coming into my house right at the moment. So, hold on one second. Okay, so I was at school. I graduated from MCP. I've been a pharmacist for over 30 years. I started working in community. And even before that, I was working in the community because in high school, I knew I wanted to be a pharmacist. So I was one of the lucky ones and I got a job in a pharmacy. And I used to look at the wall of all those birth control pills and think, how on earth do people pick these pills? I went to pharmacy school, did contraception in school, became a pharmacist, went to work in a pharmacy. I still had no idea how those pills were picked. I thought it was just some mystery that doctors just understood because they're so much smarter than us, that there's these 50 pills on that wall and they just know what to pick because it's special. It's a secret. I had no idea. So after working for a while, because I got my BS degree, I said, I really wanted to teach. I wanted to do more. So I said, I'm going to go back. And I went back and got my PharmD degree in the 90s. So it was the 2-year post-bac degree. So I was in school and someone taught contraception again. And I left that program, still not knowing how to prescribe birth control pills and why they're picking one over the other. It was just, we didn't learn it. Then I did a residency at the Boston VA. So most of my patients were men. And those who were females it was very far and few between in the 90s. And I was doing mostly diabetes, cardiometabolic stuff. So then I took a faculty position and I started working in family medicine. So in family medicine, where I'm doing chronic disease state management, at the same time, when you're a new faculty member, you really, really want to teach, and you have to wait for someone to leave or to give up their lectures that they don't want to teach. Somebody else owns that lecture. So one day an email went out to the faculty that said, so-and-so is leaving. Does anyone want to teach contraception? I read that email. I really, really, number one, wanted an opportunity to teach. And number two, I never understood how to prescribe birth control pills. And it was my mission to make sure that every single person that graduated from MCP from that moment on understood how to prescribe birth control pills, how to pick which pill. And so I had to learn it first, which I did. And I've been teaching it every year since. But I also, because I was in family medicine, family medicine residency program, I was actually teaching family medicine doctors how to prescribe birth control pills and giving the same talk. At school, it's 2 hours because we do the non-hormonal stuff too. Here, we're just going to do the birth control pills, but I actually had taught this for decades to physicians also. And it was nice to find out that nobody understood how to prescribe birth control pills, not just me. So after this, you're going to understand if you don't already understand. I'm going to make sure that you do. And that is my goal for anyone who takes this presentation or listens to it or participates in it. So I'm going to talk about the mechanism of action and the drug interactions, contraindications, side effects, health benefits, and health risks, and advantages and disadvantages. So you will learn that. You're going to be able to learn how to choose or adjust someone's oral contraceptive therapy based on the pharmacologic properties. So something I never learned in school. And recall how to utilize these charts and tables in order to justify, in order to choose those drugs. And, you know, as pharmacists, we always want to maximize efficacy and minimize toxicity. Currently, there's 17 states that allow pharmacists to prescribe or be involved in doing this. And there was a survey, and over 2,000 pharmacists identified that they were interested in providing hormonal contraception. So I do, you know, certainly hope that this just continues to expand. And, you know, I have them listed here, and, you know, stay tuned. So you hopefully will be able to, as a pharmacist, be prescribing or being involved. And so hopefully this will be helpful to you in that endeavor. Okay, so let's talk about efficacy for a second. Least effective methods: no birth control, spermicide only, fertility awareness, female condom, and withdrawal. So this is the least effective method. In terms of the most effective, implants, IUDs, vasectomy, tubal methods, 99% efficacy. Birth control shot, which doesn't exist right now. Birth control pill, vaginal ring, 92 to 95%. And this is real life effectiveness. Condom, diaphragm, cervical cap, sponge, 84 to 89%. So before we get into the meat of all of this, we have a poll. True or false? I have had questions about OCPs at work or personally and didn't know the answer. Is that true or false? %. And these are also questions that I have done this as a CE before, but I've also done this with students, and it's remarkable. All right, let's do the next one. Just trying to, there we go. Which of the following would be a good option for a woman with estrogen sensitivity? Viral, Brevicon, Junel, orthotricycline, or I do not have a clue. So 54% do not have a clue, and the other 50% is mixed between A through D as a guess. And I'm going to ask you this question again. So let's try to remember that it's all over the place. Let's do the next one. Which of the following would be a good choice in a woman with progestin sensitivity? Logestrel, Valsiva, Emoquet, Altavera, or I do not have a clue. So 56% don't have a clue, and everything else is kind of mixed. Let's do I'm going to ask you this question again. Which of the following would be a good option for a woman with androgenic sensitivity? Loestrin, Valziva, Emoquet, Ortho Novum 777, or I do not have a clue. So very similar results. More than half don't have a clue, and a big mix for the other ones. And you are working, think of this scenario, you're working one Saturday evening when you get that phone call where a woman who states she's been taking levonorgestrel, Lysina, for 2 months and has had bleeding and spotting both cycles. What do you tell her? You need to switch OCPs, call your doctor, take this pill for at least 3 to 4 months, or I don't have a clue. So you have a 50-50 chance of getting it right if you pick A or B. But if you truly don't have a clue, so a big mix between the two and some who do not have a clue. Very good. And then I think this is the last one. You're working Saturday night. You get a phone call. She's been on Lysina for 6 months. She's having bleeding and spotting. What would you recommend instead of levonorgestrel, instead of the Lysina? So you have 3 choices: Zovia, Logestrel, or VRL, or you don't have a clue and you're not even going to guess. So 66% don't have a clue, and a mix between the others. So what I do with these questions is just like, this is what I do in class. I ask those questions to the students, and then I give this lecture, and then I ask them again. So that you can really appreciate what you've just learned. So my goal is you're all going to get that, at least over 90% correct when we do that again, instead of, 50 to 60%. No, I don't have a clue. So when we talk about birth control, there are factors that determine the effectiveness. It's kind of hard to determine, but motivation to prevent getting pregnant certainly makes an impact. So if you're really motivated and you're adherent to your meds, then that you clearly have a higher efficacy rate. But other factors include the inherent biologic capacity to actually get pregnant. So that makes an impact. Frequency of intercourse. I'm always thinking about in my head how busy I am, but think about how life is and how busy people are. So frequency is going to certainly make an impact, and how well they follow instructions. And we'll talk, that's a lot about the efficacy. So oral contraceptives are the most popular method, and they're available as a combination estrogen and progestin, and also available as progestin alone. when we look at the components of oral contraceptives, and these are also called combination oral contraceptives, and if it's progestin alone, it's just a progestin only pill, but the combination of oral contraceptives, estrogenic compounds, there's 3. And up until recently, it was 2. And when a lot of us were growing up, it was just 1, the ethinyl estradiol. So ethinyl estradiol is the one that's in almost all but 2 of the products out there. So EE is the majority. Mestranol is converted in the liver to ethinyl estradiol, and estradiol valerate has been added, but it's just 2 pills. So we just want to recognize those names as estrogens. Now the progestins, there are a bunch of different progestins. I don't know if you remember any of this from PCOL. I don't. Estranes, gonanes, pregnanes, and others. So they're kind of listed here. These are the various different progestins. So you just need to be able to recognize the names as progestins. So abbreviated OCP. If you are more interested in learning more about contraception, all contraception, including a more details of what I'm talking about today, purchase the Dickey book, the Richard Dickey book. I love that book, but also contraceptive technology is where to look. So if you're going to start getting involved in oral contraceptives, the Dickey book, I think, is very comprehensive and easy to follow. And the chart that I have, I created, it's a combination of a bunch of different Dickey tables that I kind of made into one to help us for these purposes. So oral contraceptives, there's monophasic and then there's multiphasic. Monophasic is a fixed ratio of estrogen and progestins. They were introduced in 1960. They've been here for a while. The doses have been progressively decreased over the years. So when they were first introduced, it was really high dose estrogen. The lowest dose is a 20 microgram and the highest dose is a 50 microgram. By definition, quote unquote, low dose birth control is considered to be 35 micrograms or less. So, and there is nothing more than 35 except 50. So there's no in-betweens. So the 50 micrograms are reserved for special occasions, which I'll tell you about. But for the majority, it's 35 micrograms or less. Now, somebody, of course, you know how it is with drug companies and creating drugs. They said, hey, let's try to make triphasic and we'll duplicate the menstrual cycle and it'll be less side effects. And none of that panned out. So we're not going to pick pills based on that. I'm going to show you how we pick pills, but biphasic, triphasic, quadriphasic, monophasic, they all kind of do the same thing. So making those changes didn't make a difference. So we have all of those today for the combination, but we also have progestin-only pills, and those have also been available since 1960. Another term would be mini pills, and generally used for women who have contraindications to estrogen. Okay, so this is a list of alphabetical list of oral contraceptive names marketed in the United States since 2019. I don't expect you to be able to see it. The point of it is there's so many of them. Oh my God, that's the point. How is it all possible? How do we even figure this out? So there are branded generics, but they're all the same thing. Okay, so this is the Dickey book kind of tells you where they all are and what all the differences are. So in terms of failure rate or efficacy rate, most failures in birth control pills occur during patient error in the first months. So that tells me there's a really big place where pharmacists can be involved. That you know how it is. Did they get all the education at the doctor's office exactly how to do it? So we can make an impact in the community side certainly of making sure everyone's educated. In terms of efficacy, there's not a significant difference between 20 to 50. Therefore, we're going to use less than 35. So that is considered low dose. So there's just no justification of using more than 35. So using more than 35 increases side effects, increases clot risk. So in addition to birth control, there are other health benefits associated with combination oral contraceptives. So you will see these prescribed for other reasons like menstrual problems, for example. But there's actually a decrease in endometrial cancer and ovarian cancer and benign breast disease and ovarian cysts. So there's a lot of benefits, acne, that is associated with its use. And it's actually the longer you use it, the more the benefit. So ovarian cancer has a poor prognosis, as we all know, because it's very difficult to detect it early. And those who take birth control pills actually reduce their ovarian cancer risk by 40 to 80%. And the longer you take it, the more reduction you get in that ovarian cancer. Same thing with endometrial cancer. So it's more common, but not often as fatal. So the risk reduction is 50 to 60%. And the longer you use birth control pills, the lower the cancer risk is. Because if you think about it, it's preventing ovulation, it's preventing buildup of the endometrium so that you are not getting ready to implant. So you have a decrease of those cells. In terms of breast cancer, there's no sufficient evidence that birth control will increase this. So if benign breast disease or family history of breast cancer, if that's in it, there's no sufficient evidence that this is unacceptable. But if current or past history of breast cancer, of that personal history, then you would use a non-hormonal contraception. Cardiovascular complications, very low, not common because of low dose oral contraceptives, because a lot of the risks that you read about in package inserts and are historical based on higher doses. So if you're going to have a cardiovascular complication with birth control, it will tend to be in women over 35 who smoke, or in women with underlying medical problems that predispose them to thrombosis. So for example, my neighbor, herself and her daughter was like 22 or something at the time, they were running in like a marathon, and the daughter had a stroke during the marathon. She had just been put on birth control pills and she had an underlying clotting disorder. And so she actually had a stroke. She's doing fine. This is about maybe 10 or 15 years ago. Everything's wonderful. She's perfect, thank goodness. But it is rare. But sometimes that's when you find that undiagnosed clotting disorder. Smoking is an absolute contraindication in women over 35. It's a relative contraindication in young heavy smokers, so defined as over 15 cigarettes a day. If you have someone who smokes, regardless of their age, if they're over 35, that might be someone who's your progestin only person, not estrogen or non-hormonal contraception. But if you have someone who's younger who is smoking, you would use the lowest dose estrogen and obviously provide counseling and possibly change to something else. Now, this I pulled out of the package insert just to show you, so that if you have a conversation with a person, you can see as you age, your risk of dying goes up. And this is no contraception, OCP non-smoker, and an OCP smoker. And you can see when you are younger, your risk of dying is higher when you are not on contraception. That's because 15-year-olds should not be having babies and they die during childbirth. And that's what that death rate is. It's still very low, but you can see as soon as you hit 35, everything just falls apart. But you actually, no contraception, it's still higher death rate. But if you smoke, look how significant that is, especially after 40. So the risk is much higher when you smoke. All right, here we go. Here's how you choose an OCP. This is, my decades of how do they know? They're so smart. I'll never understand that. I could not pick it. This is how you do it. So that person's in front of you. They want an OCP. This is what you have to run through in your head. Do they smoke or are they over 35? Do they have moderate to severe hypertension? If they have uncontrolled hypertension, estrogen can increase blood pressure, so we wouldn't do that. If they have well-controlled hypertension, it's different. Do they have undiagnosed abnormal vaginal bleeding? Clearly, we need to work that up, not give them hormones. If they have diabetes with known vascular complications or duration greater than 20 years, there may be a risk of thrombosis. So we would not necessarily use estrogen in that patient. Have they had a DVT or a PE or past history of ischemic heart disease? If they have headaches with focal neurologic symptoms or past history of stroke, if they have current or past history of breast cancer, if they have active viral hepatitis or mild severe cirrhosis, because you remember you need your liver for the estrogen. Are they breastfeeding exclusively? So if they're breastfeeding exclusively, it's not contraindicated, but estrogens may decrease breast milk production. That's a little controversial, but so it's a maybe. Major surgery with immobilization within the month. So a lot of that is your increase at a clot risk. A lot of it was for the higher doses, but it might be something you might wait on. Past history of cholestasis with oral contraceptive use, we wouldn't use it, and family history of thrombosis. So if they have any of those, and the answer is yes to that, it's positive for those things, they might not be able to use combination oral contraceptives. We would consider a progestin only or another option, right? A non-hormonal or hormonal. So those are the yes history. What do we do for everyone else? And this is the drum roll, please. How do we pick the pills for everyone else? If they're negative, here's the thing. And this was sort of almost disappointing. You can give them anything. They'll all work. It doesn't matter. It's not special. So this is how most people pick in general. They don't think about anything. They just give them what in the past it's, well, what do I have samples on? Or did the person see an ad? Did the person come in and say, my sister's on this one, this is what I want? So that's how it's done most of the time. And some doctors, what will happen is they just have a favorite they just give to everyone. The other thing, as we all know, is insurance coverage. So what's preferred and what's covered. So we used to have birth control that was free for everybody, and that got taken away, as you know, in 2016. I don't know if it's back in place. I don't think so. Massachusetts still covers birth control for everyone. So you'll have to let me know in the chat field what happens in Connecticut. So it's still $0 in Massachusetts. Now, this lecture would not be fun, and I would not be passionate about it if there wasn't more to it. So there is more to it. So it's if there's an issue, if there's a problem, if there's side effects, that's when we will specifically pick certain pills special. And that's what I'm going to teach you. This is the demystification part. So estrogen related side effects like nausea, breast tenderness, and bloating. So those are hormonal side effects. The progestin component can also cause side effects, and it depends on the type of progestin. And this is what I didn't understand evidently in school, or I was sleeping. I don't know. So it's the type of progestin, because progestins actually have an effect on estrogen, progestin, and androgen receptors. So they have estrogenic, progestational, and androgenic properties of the progestin. So it is not about the doses of the hormones. It's about the type of hormone and how they interact together. Because remember, like almost all the birth control pills are ethinyl estradiol. So it's ethinyl estradiol mixed with whatever progestin it is at whatever doses it is, whether it's monophasic, biphasic, etc. So that is how it's decided what the side effects are. And I'm going to teach you all about that and how to do it. So you are going to need to pull out that Dickey table that has been provided to you. I call it the Dickey table. This is a different table that is in, like textbooks. You'll see it everywhere. So just another kind of global way to look. These are the progestins. Remember, I told you the whole list of progestins that are there. This is just so I want you to understand that progestins have estrogenic activity, progestin activity, and androgen activity. Some have more than the others. So you can see the first generation, the second generation, the third generation, they have different activities. Now, for me, what I say to myself is, I can't possibly memorize this. So you would have, if you were doing GYN, you might remember one from each group, and that's what you tend to prescribe. But for the rest of us mere mortals, we're going to look it up on a table. So I want you to take a look at the Dickey table. And so I took several tables from that Dickey book, and I kind of combined them for our needs and for my needs. So when you look at this table, there's a drug profile, that's kind of numbered, and that corresponds to all different charts within that book. But there's the drug listed, and on the next column, and you should be looking at your Dickey table. The third column is percentage any spotting of bleeding in the third cycle of use. Okay, percentage spotting and bleeding. The next column is estrogenic activity, and the next column is progestational activity, and the next column is androgenic activity. So you're going to use your Dickey table to answer those questions I asked you. So these are the 4 columns you're going to look at with those different scenarios that we went over. So let me give you an example. If somebody has an estrogen sensitivity, this might be a person who complains, or they have a history of migraines, that they either have this as a history, or we gave them a pill. We gave them birth control pills, and now they're having migraines, or they have a history of menstrual cramps, or they have severe nausea and vomiting during pregnancy, or you give them birth control pills and now they have nausea and vomiting. That's an estrogen sensitivity. If they had pregnancy-induced hypertension, if we had a patient with an estrogen sensitivity with these type of complaints, then we would pick a pill with low estrogenic activity. So I want you to use the Dickey table, and I want you to talk. If you're live, if you're in person, I want you to talk to the person sitting next to you and use the Dickey table to answer this question. If you're at home or at the office, I want you to pull up that Dickey table, and I want you to look at the column that says estrogen activity and pick a pill for this person. So you want to find a pill with low estrogenic activity. And it's, I don't remember which column it is. And then when you're done, go ahead and answer. So you're going to look at that 4th estrogenic activity. So we still have a big mix here. So let me show you. So I don't have any, I don't have a clue. So let me show you how to do it. So the answer is C. So whoever picked C. So here's the chart. If you're going to choose one, here was the choices you had. So in order to pick low estrogenic activity, here are the 4 choices you had. You need to look at the column and pick the one with the lowest incidence of estrogenic activity. Okay, so we had a big mix here. I hope that that kind of clarifies how to use the chart. Let's do another one and see if we can improve, because I think we're at like 25% of each. Let's see if we can do better. If someone has a history of progestin sensitivity, let's say they got a pill, they filled the prescription for a pill, you gave them a pill, a doctor gave them a pill, whoever, or they have a history of excessive weight gain, appetite, tiredness, varicose veins, toxemia during pregnancy, or they got a pill and now they're gaining weight and have, or they have PMS. They have a history of PMS, or you gave them a pill and now they're bloated with headaches and depression and getting PMS after they got a pill. We're going to pick a pill with a low progestational activity. So I want you to use the Dickey table. See if you can look at the right column, the one with the progestational activity, and pick a pill with low progestational activity. If you don't have the chart, you really can't, answer this question if you don't have the chart in front of you. So talk to each other, take a look at the chart. This is fun to do when I'm in class with, 250 students and they're all buzzing and talking. I miss that live interaction of a big buzzing and noise and chatting. All right, what did y'all get? So 50% of you said B. We still have someone who doesn't have a clue. So the answer is B. So we're doing better, So here's what we're looking at, everybody. If we're looking at progestational activity, 0.4 is lower than 1.5, 0.8, and 0.8, right? So it's just numerical. That's why it's Valziva. So let's see how you do on the next one. Androgenic sensitivity. This is somebody with a history of irregular heavy menses. Physical exam may reveal oily skin, hirsutism, acne. We would use a pill with high progestational activity and low androgenic activity. So you need to look at the Dickey table and look at two columns. You want to pick a pill with high progestational activity and low androgenic activity. So let's look at the next question. Now remember, you need to pick high progestational and low androgenic. So look at low estrogen, Valziva, Emoquet, Orthonovum 777. Take a look at your chart, talk to the person sitting next to you, see which one you would choose if this person is in front of you. Okay, so the majority has picked C. Which is correct. So we're going to look at if we want high progestin, low androgen. Of the choices you had here, we would pick the one with the highest progestin and the low androgen. Now, what's the difference between 1.5 and 1.7? Is it significant? Who knows? But there is a big difference between 0.17 and 0.8, at least numerically, right? So if you had a person who presented that way, that's how we would choose it. Now, in somebody with severe acne, that person may benefit with an oral contraceptive with high estrogenic activity and almost no androgenic activity. So take a look at your Dickey table. Let me just show you. So if you're going to look for, you're looking at your Dickey table, somebody who has a history, they have cystic acne or really bad acne. We want high estrogenic activity, low androgenic activity. Remember, this is pharmacologic activity. This is not dose. It's on the pharmacologic activity. So if we're going to pick one of this group on this screen, for example, this is how we would look at the two columns, okay, in comparison. So we can rule out the other ones just based on the fact that these have higher estrogenic activity and lower androgenic. All right, breakthrough bleeding and spotting, most very common complaint, and it is the most common reason women discontinue oral contraceptives. But it's more common with low dose and progestin only pills, and occurs most often during the first cycles. 1/3 to half women who bleed during the first cycle will not bleed during the second cycle, and it continues to plateau to the second to fourth cycle. So we tell women, just wait, 3 or 4 cycles, wait a few cycles before we start switching. Why do we have breakthrough bleeding? It can be due to inadequate amounts of estrogen and progestin in the OCP. And if that's the case and it continues, we make a change, or an imbalance. It can happen when people miss pills. So make sure you ask, are people missing their pills? It can also happen with drug interactions. And we also want to make sure someone isn't having a problem. So some type of infection. And there are other reasons. So it's easier if we're going to switch a person who has breakthrough bleeding, it's easier to use the chart. So we choose a pill with greater endometrial activity. How you do that is you can use a higher progestin dose or more androgenic properties or multiphasic. These are all things you can do, or you can look at the chart and just pick one with the lowest breakthrough bleeding. So here's another question that I asked you earlier, and we did not get this right. So you're working, you get a phone call, she's been on it for 2 months. Do you tell her to switch OCPs, call your doctor, or take this pill for at least 3 to 4 months? Or do you still not have a clue? And I'm going to get fired and say I didn't learn anything. What do you think? I'm never getting asked back to speak at Connecticut Pharmacists Association ever again. Oh, good. Well, 97% got it right. So let's see. Excellent. You want to wait 3 to 4 months before switching. How about this one? You're working Saturday night. Now the person's been on Lacina for 6 months and she has bleeding and spotting. What are you going to recommend? So you're going to use your Dickey table and you're going to look at the percentage spotting and bleeding. And you're going to pick one instead of the Lacina. Zovia, low ogestrel, or Viorel. So you want less spotting and bleeding. Speak to the person sitting next to you. If you're at home, take a look at your Dickey table. And what do you think? So 2 people still don't have a clue. Let me show you. So we have the majority picked low ogestrel with a few picking Zovia and Viorel. So the reason the Zovia was a trick question, because remember I said we don't use 50 microgram pills in anyone. So we don't. So that was a trick question. So those of you who got it right, that's, excellent job. But so when we're looking at percent bleeding and spotting of the remainder, the reason why it's no ogestrel is it's 9.6% compared to 26.5 and 19.7. Excellent. Extended and continuous regimens. Why is this? We have 24, 84, or daily birth control pills. The 24-day active pills, you have three days with that are pill-free. The 84 days of active pills, it's followed by 7-day pill-free interval. And then there's daily pills every day. So using daily pills or an other variation, before there were actual pills available at that time, we did this all the time with monophasic pills in order to not get your period on purpose. Also, people with significant menstrual problems, menstrual pain, by taking it every day and not getting a period, you totally avoid menstrual pain. So no periods daily with daily pills, which can be very exciting and also saves a lot of money with product, as you can imagine. So here are the available extended cycle and continuous regimens that are on the market. Of course, we're going to have to pick things that are covered by people's insurance, depending on your state. Some states are covering everything for $0. If you use monophasic pills, the 21 days of monophasic pills, the prescription has to be written, take continuously. So for 21 days, and so that the last 7 days is blanks. So you would just do the continuous pills. So what we have to know as pharmacists, and remember I said that the failure rate is higher those first months when people first start, is understanding when to start birth control pills, Sunday or day one or quick start. So when you look at the birth control pills, they're all labeled starting on Sunday. So all birth control pills have 21 days of active pill and 7 days, this is of the combination, 7 days of blanks. And so every 28 days is a new cycle, and they're all labeled with a Sunday. A Sunday start is you start taking your pill. This is the very first time you ever start taking pills. If you're a Sunday start, you take it on the first Sunday after you get your period. So if you get your period on a Sunday, you start on Sunday. You get your period on Wednesday, you start on Sunday. You get your period on Friday, you start on Sunday. That's a Sunday start. Every time you open a new pack every 28 days, it's going to be Sunday. If you're going to be a day one start, you start on your first day of your period. Starting on the first day of your period protects you from that day one. A Sunday start, you have to use backup for 7 days, a backup method of birth control. So when you get your pill packs, it comes with little stickers so you can change the date. So if you get your period on Tuesday and you want to start on Tuesday, so you're protected from that moment, you can do that, and you just change the label on the pill to start on Tuesday. There's a quick start, and you start the day of your appointment. So that means you come in, that doctor or yourself, if you are prescribing it, doesn't think that that person is reliable. They could start that day. And if they start that day, you use a backup method for 7 days. So remember, first 21 days are active, then 7 days of are blanks. You can just throw them in the trash or take them. Most of them you can throw out. Some have a small amount of estrogen in them. Some contain iron. 1 pill a day, the same time every day. Tell people when to expect their period, which would be within that last week of blanks, and what to do if she misses a pill. And remember, this is no barrier to STDs. So still need one of these. So I always joke in classes, if I wore this to school, if they would fire me. It's a condom dress if you can't see it. So here's what it looks like the Sunday through Saturday. So you can see, and it comes with stickers so you can change the day if you're not going to start on Sunday. And the last week, that's when you're going to get your period. So you can explain that to people. What do we do if we miss a pill? This is a common phone call that you might get. So there are guidelines in this package insert. You can use the guidelines. It's sort of in general for all. It's important to know how to answer. The directions are a little bit different between regular OCPs and the continuous. You can look up each one individually, but reminding people to take their pills around the same time every day. Use a pregnancy test if you don't get your period during that last week, unless you're on continuous, and then you just have to take them every day. Here is, in general, if you miss a pill, you take it when you remember. Okay, or if you don't remember until you open your pill packet the next day, you take 2 that day. If you miss 2 and it's in the first couple of weeks, then you take 2 today, 2 tomorrow, and then go back to usual. But you need to use a backup method for the remainder of the cycle. If you miss 2 and it's in the 3rd week, you still do the same 2 today until all active pills are taken. So 2 now, then 1 daily, use a backup for 7 days. And if it's 3 or more, you kind of do a do-over. If you have people that are continually missing pills, this is not a method for them. We need to help them find a different method. Remembering side effects, most common in the first 3 cycles. When you're getting used to that, try to ask patients to wait 3 cycles before changing them. Remember, most of these things will spontaneously disappear, including breakthrough bleeding, which is the most common. In terms of side effects, the typical ones that we see is you might have some nausea, weight gain, breast tenderness. Weight gain usually is not tremendously significant. Some of it might be related to some swelling or edema in someone. Remember, we know that's a progestational effect now. So if that happens, we can switch their pill to something with low progestational activity. Same thing if somebody had acne. If we give somebody pills and they get acne from it, then we're going to switch them to something with low androgenic activity and high estrogenic activity. That's how you manage some of these things. Somebody has headaches now. We gave them a pill, they have headaches. We know that that's an estrogenic activity. So we'll look at the Dickey chart, we'll pick a pill with a different activity. That's how it's done. When you have people with severe abdominal pain, chest pain, severe headaches, eye problems, these are pill danger signs. This is when they have to go to the emergency room. This is not something that we're fooling around with. In terms of drug interactions, these are undisputed anticonvulsants. This is the only time you might see a 50 microgram pill is if there's a drug interaction. Okay, so document that if you see it and it's prescribed, and make sure it's because of that. Sometimes there are patients who have gotten pregnant on lower doses. It's very rare where they might get a 50 microgram. Now, these antibiotic drug interactions are a little bit more controversial. In my opinion, I would recommend if you take antibiotics, I have seen people get pregnant on antibiotics while they're taking this, but remember, they're not finding this out for a month or more later. So not everyone's going to make the connection. So for a short course of antibiotics, use a backup method. That's my recommendation, even if it's not in the package insert, to do that, because ethinyl estradiol is conjugated in the liver, it's excreted in the bile, it's hydrolyzed by intestinal bacteria and reabsorbed as active drug. And antibiotics reduce the population of intestinal bacteria. So theoretically, it makes sense. And, you know, it won't hurt them to use a backup method. In terms of returning of fertility, that's another common question. Everyone's different, but traditionally we recommend 3 months so that they can tank up on prenatal vitamins if they're trying to get pregnant. So everyone's different, usually pretty rapid return to fertility. Now, in terms of lactation and breastfeeding, estrogens inhibit the action of prolactin in breast tissue. So this is also controversial, but can decrease milk quantity and quality. So progestin-only pills or progestins have no effect. So when do we use progestin-only pills, and what do we need to know about it? They are less effective, and there is an increased risk of ectopic pregnancy, but in anyone that needs to avoid estrogens, this might be a good option for them. Here's the thing, progestin-only pills, you have to literally take it at the same time every day. It's taken on the first day of menses. It's continuous. One thing people don't realize is if you are 3 hours late or miss one pill, you need to use a backup method for 48 hours per the manufacturer. Conservative recommendations are 7 days. When I gave this talk 20-something years ago, one of the physicians in my group took a big breath. He went like that. So he had he actually had a relationship with someone in the practice who got pregnant, and this is what had happened. They ended up getting married and stuff. So women like their birth control pills in little pink packets, but if you can see here, it's continuous. You could take it out of a stock bottle. So interesting. All right, so with that, I'm just gonna come back on and see if there's any questions. Feel free to link in with me, or I hope that this was helpful. And I hope that it gave you a starting point to, if you're going to be involved with birth control, to at least know where to look.
Awesome. Do we have some questions from the audience in the room here? I have to say, Dr. Goldman, I've not been so excited about contraceptives since college. So you made me feel much better. Let's see.
What's the status in Connecticut for prescribing, pharmacist prescribing?
So that's a good point. I was going to mention that. So right now, they do not have prescription authority for contraceptives. That said, we do have an advocate and a champion in the Department of Consumer Protection, who is the head of drug control, who is a pharmacist and who is very interested in having this happen. Part of our problem is that we have a public health committee in the legislature that is vehemently opposed to expanding too much authority to pharmacists. So we're in a constant sort of legislative regulatory battle on that front. That said, you pointed out some great data and information on the NASPA website that goes exactly to this. And so we've been talking with NASPA and with other organizations about how do we put together a more aggressive stance and try and push both contraceptives and smoking cessation authority through. And we'll see what happens in this next session. One thing that for better or worse, COVID has done from a legislative standpoint is to show our legislators the breadth of capability that pharmacists do have and how that can be integrated more readily into the overall healthcare public health system. So
we do have a question.
Oh, okay. We do have a question.
One question. I want to make sure I answer because I know I did the rapid Boston talk, but it was still a long talking of me. What is the impact of obesity on the risk of thrombosis with OCPs? So that's a really good question. So remember, OCPs themselves are not increasing your risk of thrombosis, except if you are having the high doses or you have a hidden clotting disorder. So there's no specific guidelines for thrombosis with obesity, but there are specific guidelines for some contraception. Certain contraceptions aren't appropriate based on weight, where you can't use them over 195 pounds or so forth. So if you end up doing contraception at your practices, it's specific. So I recommend the Dickey table. So those are the type of things I get into the second hour. If an RPH prescribes, are we assisting in someone avoiding an OBGYN exam? I don't think so. People still have to be responsible for going to get an exam. So birth control is unrelated to me to having an annual exam. So I think that we're prescribing for an annual exam. And I do believe ACOG is also in agreement with this being accessible to more women. So I think if they're not being examined, the same thing if we were prescribing, had prescriptive authority in the community for chronic meds for hypertension, we still want them to go see their physician at least once a year, right? So same thing.
Any other questions from the room? From the virtual room? No?
Well, thanks,
well, thank
everyone.
you, Goldman. That was fascinating and exciting and a lot of fun. I'll put it that way too. So The code for this program is the word therapy, THERAPY, popping up there right now. Therapy.
Bye, everybody. Enjoy your
Thank
day.
you.
Thank you for
Bye-bye.
your attention.